Now, lumbar plexus block, in a nutshell, is a complex block. But as Professor Morrigal always says, anatomy is the key to it. So understanding the anatomy is fundamental. Why is the screen like so here? Okay, these are some of my disclosures. I receive equipment support from some of these companies, for which I'm very grateful, but it's usually relations, usually gastronomic, otherwise nothing beyond that. However, this morning I like to mention, without any financial interest, I think some of the images you will see today are truly fascinating, not because they come from Hong Kong, but I think there is an element of technology involved here. We've been using this, what one of the providers, I wouldn't mention it, but you will know it, is they call it a single crystal technology, which makes low-frequency transducer images truly spectacular, even if you're imaging at a depth. And you can see how this single crystal technology has produced immense advantages. So these are some of my objectives. I'm going to talk to you some of the basics of the anatomy. I'll share with you some new insights into the lumbar paravertebral sonoanatomy and how you could use this to perform lumbar plexus block. This is quite irritating. Is it possible to get this, Jim? Can you look into this, please? Okay, this is how I would talk about, you see this one here? I can't really, okay. Actually, the lumbar plexus is formed by L1 to L5. It's formed within the substance of the psoas muscle. So if you can image the psoas muscle, you will see, maybe conceivable that you may see the lumbar plexus in the posterior part. This is where anatomically it's been described. Okay, if you look closely into this cartoon, it's actually the nerve roots emerge from the intervertebral foramina between the anterior fleshy part and the posterior membranous part. And there's also some anatomical literature saying that it can be behind the psoas muscle as such as an anatomical variation. But this is where it's located in the posterior part of the psoas muscle. So as you can see, the psoas has been slit longitudinally, and you can see the lumbar plexus within the psoas muscle. Again, you'll also note that the psoas muscle has many tendons. There are intramuscular tendons within the psoas muscle. It's formed cranially, and they kind of conglomerate and they fuse as a psoas tendon distally. So everything white and bright inside the psoas is not a nerve. So that is the important take-home message. Okay, you can see the nerves are actually quite large. These are the plexus of nerves which are formed within the substance of the psoas muscle. So when you do lumbar plexus block, we are essentially injecting the local anesthetic somewhere in the posterior part of the psoas muscle in relation to these nerves that are in the posterior part of the muscle. Now I'd like to share with you some anatomical information from this Visible Human project. As you can see, this is an online anatomy that you can cut it up in the comfort of your own computer, and you can not only look at a single plane, but because this is digitized, so you can look at a multi-planar view, and that will allow you to validate what you are seeing. Now, relevant to lumbar plexus is the area that we are going to do the scan in the lumbar paravertebral region, in the lumbar region. So this is something you've been shown many times, but if you look very carefully, this is the psoas muscle, this is the quadratus lumborum muscle, the vertebral body, the transverse process, the articular process of the vertebra, the erector spinae muscle. So this is really our area of interest. Now, when you look at the lumbar spine, you could do a transverse scan at the level of the transverse process, but this would not be very good because you have the acoustic shadow of the transverse process. And if the nerves are located in the posterior part, then that would obscure the nerves, if you may. So therefore, you could have another where you are scanning between the two transverse processes. What do I mean by that? Now you see, we are at the level of the articular process. And this is true even in the thoracic region, as Dr. Van Gaffen has shown in Luit's paper in Paravertebral in the thoracic region. You can see here this is the articular process, but now you can see the nerve root as it is emerging from the intervertebral foramina. You can see the psoas, you can see the quadratus lumborum, you can see the erector spinae muscle. However, ladies and gentlemen, I'd like you to focus in this area. You can see that the nerve root emerges, but unlike the intercostal nerve, it does not enter the intercostal space, if you may. It does not enter the psoas muscle because the nerves are descending caudally at an angle. So it enters the psoas muscle at the level below, if you may. So what you see here is the nerve root from the level above. So now this is the L4 vertebra. So this is the L3 nerve root adjacent to the L4 intervertebral foramina. So this is the L4 nerve root. This is the L3 nerve root part of the lumbar plexus. Also, you will see that the nerve root is actually between two parts of the psoas muscle. You can see a thin dividing line between the two. Okay, so this is the area of interest, if you may, that we are looking at. So this is what has been described as the psoas compartment, and that's where the lumbar plexus is located. Okay. This is close to the medial part. This is the psoas compartment. What about the sagittal anatomy? They talked about, Dr. Gray mentioned about the ultrasound trident. So this is essentially cranial, this is caudal. These are the transverse processes of L3, L4, L5. This is the sacrum. This is the psoas muscle. And you can see within the substance of the psoas muscle, the lumbar plexus nerve roots are formed. And this is essentially the L2 and the L3 nerve root here. Now, multiplanar view is another way of looking at anatomy. This is, I believe, a very interesting way of looking at anatomy because you don't have to cut it up. You don't expose fascial planes. There's nothing wrong with that. But you can see it in vivo. And tomorrow I'll be talking something else more about 3D, 4D. That's another way we can look at it. Now, if you see here, I have a reference marker here. Now, this reference marker in that 3D volume, if you have a sagittal or a coronal view, you will see that same point in the 3 views. So now, if this were the lumbar nerve root, L3 nerve root, when I expose the sagittal view, you can see the L3 nerve root here. You can see the psoas compartment. There are two parts of the psoas muscle. It is in the posterior part of the psoas muscle, and it's anterior to these transverse processes. This is what anatomical literature describes, and this is what is most commonly seen. I think the coronal view is also very interesting because you can see here how the nerve root, as they emerge, they descend caudally at each level. And the lumbar plexus is formed within the substance of the psoas muscle. Remember, they are not laterally in the psoas muscle. They are somewhere in the central part of that psoas muscle. Because this is, has some technical importance. Because if you insert the needle too lateral, and you're using motor response, you're never going to get a motor response because your needle will never come in close contact with the plexus. If you go too medial, you may be very close to the spinal artery, so you don't want to go too medial either. So you want to place the needle somewhere in the central part of that psoas muscle. So this is what the anatomy. This is the transverse anatomy at the level of the transverse process. This is the transverse anatomy at the level of the articular process, or the intertransverse scan, and the intertransverse section. This is the sagittal, and this is the coronal. Okay, now let's take a look at how does the sonoanatomy appear if you're going to put this into perspective. Okay, now for those of you who are wondering what this is just to cut the boredom. This is a very famous Indian temple close to Mysore, India. As you can see here, beautiful three-dimensional images of some of the Indian gods and goddesses. Okay, when you do a scan of the lumbar paravertebral region, patients in the lateral position, this is the intercrystal line, this is the midline. This is a point about 4 centimeters from the midline. This is where we would traditionally insert the needle if you're doing a nerve stimulator guided lumbar plexus block. So let's call this the sagittal scan line. This is where we would do the sagittal scan if you're looking for the ultrasound trident, lumbar ultrasound trident. Now I'm going to do a transverse scan. This is a variation of the technique that Professor Morrigal and the group, Lucas Kritschmeyer, described in cadavers. But what we do is we have a little twist to this. Rather than do a true transverse scan, we're doing, if you notice here, we're doing an oblique transverse scan. We are trying to visualize, you can imagine in your mind's eye that I'm trying to see towards the anterior part of the vertebral body. As you know, in the anterior part of the vertebral body, you have the IVC and the aorta. So I'm literally trying to insonate the IVC if I'm doing a right-sided scan, and if I'm doing a left-sided scan, I'm trying to insonate the aorta. So anything that comes in the field of vision is relevant to what I want to know when I do a lumbar plexus block. Now, this oblique scan you can perform at the level of the transverse process, as I said, which means we are doing a transverse scan in this lumbar paravertebral region at the level of the transverse process. But as I alluded to previously, it's not going to be very useful because you have the acoustic shadow of the transverse process, as you see here. This would be where the acoustic shadow would lie. Now, if I just projecting this cartoon, you can see here, this is how the beam is going to be insulated. But because this is in the shadow, you're not going to see that part of the anatomy that is relevant for lumbar plexus block. However, what I noticed is very interesting is part of the energy has a possibility to enter the neuraxis via the interlamellar space. So when you do this window, it's possible to visualize the central neuraxial anatomy. And this can be useful if I'm looking at the mechanism of spread after lumbar plexus block. Does epidural spread occur? Yes. Maybe another time I will show you some of these data. The next is, if I now look at the ultrasound image, this is what you are seeing. This is anterior, this is posterior, this is the vertebral body. As I said, bone is always your friend. Whether the patient is 19-year-old or 90-year-old, you will see the bone as a dark shadow with a hyperechoic rim. You can see the vertebral body, the transverse process. This is the inferior vena cava because it's a right-sided scan. The muscle I see here is the psoas muscle. The muscle I see here is the quadratus lumborum muscle. This is the retroperitoneal space. If you scan higher up, this is where you would see the kidney. Because I'm scanning below the lower pole of the kidney, I do not see the kidney in this window. However, I'd like you to focus here. You can see two hyperechogenic lines. This is actually the spinal canal. This is where you are seeing the edges of the dura, the hyperechogenic neuraxial, and this is the thickle sac here, if you may. Okay, so this is what I labeled for you. Also, you can see here, this is the articular process of the vertebra. Now, this is the neuraxis, and I sort of depicted that in this anatomy. So, it takes a bit of synthesis of this anatomy in your mind's eye, but once you get it right, and you have some images in your handout, so I'd like you to go home and think about it, and you will find it very easy to delineate. Okay, the next is the intertransverse window, or the window at the level of the articular process. Now you move the beam either slightly cephalad or caudad. Now, I go cephalad because when you look at the intercrystalline and you're doing a scan at that level, it's not possible to go caudad, although I would like to go caudad, but the iliac crest usually comes in the way. So you got to go slightly cephalad to that, hoping that your level is somewhere between L3 and L4. This is easy to delineate, and Jin will talk to you about how to identify a given lumbar interspace. Okay, we're going now to the level of the articular process. Now, I'd like you to see here too that your scan is very close to the level of the intervertebral foramina. So if I do a scan like so, in my original thinking, I said I may be able to see the intervertebral foramina, I may be able to see the nerve root, I may be able to see the lumbar plexus as it is. So this is basically the anatomical projection. So this is the area of interest that I have within this green pane here. And this is what you see. Truly fascinating image you can see here. So this is the inferior vena cava, the vertebral body. Now you don't have the transverse process. You have the articular process. Now there is no neuraxis here because this is where the spinous process would form, and this would be the posterior part. You can see the psoas muscle. You can see there are many hyperechogenic dots, which are the intramuscular tendons. You can also see the rectus spinae muscle. You can see the quadratus lumborum muscle. I'd like you to focus here. This is actually the intervertebral foramina. This is where the nerve root emerges. In many individuals, we can see the nerve root as it exits the intervertebral foramina. Also, you can see in the posterior part of the psoas muscle, you have the hyperechogenic lumbar plexus. It's also in a hypoechogenic compartment between the two parts of the muscle, as you can very clearly see here. It's in that compartment that you see. So that remains the psoas compartment. This is the sagittal view. Although we described this originally, I find the transverse oblique view so good that I have stopped using this particular window. So in the interest of time, I will demonstrate to you how you can use it to perform it. Now, many of you in this audience must be saying, is he really seeing what he's seeing? Now, if you're a scientist, you validate things. We have. We've done an anatomical CT MRI correlation of what I just showed you. In a nutshell, you can see here, this is the transverse process window. You see in the CT, this is the transverse. This is an MRI from volunteers. And you can see here, in this you can see the nerve root is an MRI, but in the ultrasound, because the acoustic shadow, you can't see it. But what is of interest is the intertransverse window. You can see in the MRI, the nerve root exits, as I just showed you here. It enters a hyperechogenic space. It is a triangular space which is filled with fat, which is the hyperdense shadow here. This is the true lumbar paravertebral space. Now, we talk about the lumbar paravertebral space in our regional anesthesia literature. Nobody really knows what we're referring to. But this is exactly what we are referring to. A lumbar paravertebral space, this is the lumbar paravertebral space. This would be your lumbar paravertebral space here. Now, if you look very carefully, there are two parts of that muscle here. And the nerve root is actually wedged in that two part. You can see it very clearly here. This is the lumbar plexus. Okay? No doubt about that. You can see in the sagittal view that the lumbar plexus is actually wedged between the two parts of that muscle. It's in the posterior part of that muscle. Therefore, Dr. Gray, this is the psoas compartment we were talking about. So if you inject in your groin, there's no way the local anesthetic can get to that part of the compartment in the lumbar plexus, within the substance of the psoas muscle. It can get to between the psoas and the quadratus lumborum muscle at L5 level, maybe. That's where the femoral nerve, the lateral femoral cutaneous nerves are there. You can see the ultrasound trident. And this is exactly what I showed you. In the MRI image also, you can see how the nerve roots actually exit distally. Okay, so how can we use it to perform lumbar plexus block? Okay, this is the technique that we have been evaluating, and you will soon find this in print. This is again some beautiful images from a retreat we had of regional anesthesia of in ISURA in south of India, again close to Bangalore. It is the Rajiv Gandhi National Park. Dr. Tom Clark was there with us there. Okay, when you look at the paramedian sagittal scan, this is the ultrasound trident we talked about, and we've described. You perform an injection like so in plain technique, and this is through the acoustic trident. But this is our experience now. We have that we perform the paramedian oblique sagittal scan. So these are the landmarks. We often combine it with the parasacral block if you're doing lower extremity. You can see here we are doing a paramedian oblique sagittal scan. The needle's introduced about 4 centimeters from the midline. But again, look how the ultrasound beam is being insonated. It's with a slightly oblique twist, as I say here. So this is your area of interest. So as a simple tip, because I've come all the way from Hong Kong and you want to go away with all these things in your mind, I'll give you a simple tip. Sometimes when you do the scan on the right and left, you know, whether you're right dominant, left dominant, it can be a little difficult. A simple tip for you is, irrespective of whether you do a right-sided or left-sided scan, my suggestion would be keep the orientation marker pointed outward. Means it will be lateral. So every time you see the image, the lateral part would be the same. So the image on the screen would be the same whether you're doing a right or left-sided scan. So you don't have to tax your brain too much. Okay, so this is what we are seeing. And this is a lumbar paravertebral space. The needle would be introduced exactly where we normally introduce the needle, at 4 centimeters from the midline. And you can see here, the needle is introduced medial to the transducer, 4 centimeters from the midline. And we always use nerve stimulation because it's a deep structure. You may not always see the lumbar plexus, as I showed you in that volunteer. But the aim is to guide it to the posterior part of the muscle, avoiding the transverse process window. You want to insert it at the level of the articular process. You can see the needle being guided towards the lumbar plexus. And once you contact the lumbar plexus, as you see here, the needle is being introduced. It is now going to be advanced further. And once it comes in contact with the nerve root, that's lumbar plexus block. Okay, now how does it look when you see a needle in contact with the nerve? I'll just show you a few images. As you see here, this is exactly when you get the motor response. You see a ipsilateral quadriceps response. And I turn the transducer. You can see how the needle is indeed in contact with the nerve root. And this is the same patient in both the sagittal and the transverse oblique view. You can inject your local anesthetic and you will see spread within that posterior part of the psoas muscle. Okay, in conclusion, I've been able to show you, I submit that I have shown you some new insights into how to define the anatomy of the lumbar plexus. However, it is a technically demanding block. Actually, there are very few indications of performing a lumbar plexus block. If you look at the literature, there isn't many evidence-based indications of performing lumbar plexus block. It is a very sexy block to do. But beware that this is a block that has potential to create severe complications, some potentially dangerous complication, which you can avert, you can avoid by just doing a simple fascia iliaca block or a femoral nerve block. So be prudent. However, when you have to do it, today it is possible with the technology available to identify the anatomy very clearly. It's possible to perform real-time guidance. I've shown you 2 ways of doing it. I prefer to do the oblique view now because I can see I can create a three-dimensional image of the anatomy in my mind's eye better than just looking at a single 1 millimeter slice of that ultrasound trident. There's limited data today. We are performing some research in this area, both in slim patients in Hong Kong, as well as some obese patients south of the border, in collaboration with some of our colleagues in the United States. Stay tuned. Thank you for your attention.